We thought it would be important today to update everyone on where the eHealth Exchange is headed, so our roadmap. And this is going to be largely technical, but of course there are certainly components that are process and policy oriented, so we'll get to those as well. And of course, it's important that we share our roadmap so that you have an idea regarding our vision and you can help us course correct so that you know where or how to plan and so that we can continue to gather your feedback and do that course correction. Before we share where we're headed, it's probably important to spend a few moments looking at our logic. So we want to look at the drivers that are shaping the change, as well as the key issues that we're going to face. And then we can take a look at the strategies that will get us to where we need to be. So I'm not going to spend a whole, I could bore you to tears ad nauseum on the drivers with interoperability across the US, but you understand those very, very well. But you know what, the one that strikes me the most is really the standard of care. So someone mentioned this morning how patients now have this expectation that they have access to their detailed information. And of course, that's a huge shift, and I believe a wonderful shift. But we also have this shift with our clinicians. So as I was mentioning this morning, 10 years ago, we didn't have meaningful use. We didn't have a lot of standardized data. And besides lab results going around, there really wasn't much data being swapped. And if you look at today, or actually, if you look at a few years ago and you would speak to clinicians, and of course this is a stereotype, some, some were really basing their workflow based upon information they get during transitions of care. But others might say, you know, that's great information, but there's too much of it, and I don't have time to review it. And now I believe that more and more you're seeing clinicians say, I don't have time to read it, but I'm going to make time to read it. And and it's the only way that I can be most likely to provide safe and effective care. So that standard of care shift, which I believe is happening now, is probably the most prominent. And then we've got value-based care. You know, and it's certainly not happening as quickly or as prominently as many people originally believed, but it's absolutely out there. And I would venture to guess that the vast lion's share of providers out there have at least one value-based care agreement, but maybe it's not their entire ball of wax. And of course, there's the desire to reduce duplication in value-based care, but maybe much more importantly, there's the concept of shared patient responsibility. And so if there are multiple providers, multiple physicians with responsibility for a patient, they really have to exchange data and be on the same page regarding the treatment that's been provided to a patient. And there are new capabilities. So of course there's the RLS, the record locator service, where you can see where a patient is actually treated before you query. And there's the promise of FHIR, where maybe instead of getting a War and Peace clinical document, which I happen to love, maybe you could get a condensed version and say, hey, I just want to look at medications and problems, or maybe I just want to look at lab results. So there's the new things here that are driving excitement and driving up the volume of information exchange. The data is exponentially more consistent than it was 7, 10 years ago, and therefore it's much more valuable. And of course, some of you may scoff at this, but the price point has gone down, way down. And especially if you look at something like care equality, where providers and other healthcare organizations can join one home network and then branch out to multiple other networks. So they can branch out to Athena Care, and they can branch out to NextGen and ECW and Commonwealth, SureScripts, et cetera. That really brings the provider's price point for interoperability way, way down. So if we want to look at the key issues, I would say that we have an incredibly valuable solution today. You're able to search within your network. You're able to pull back very rich information. But if you want to look at it a little more critically, you could say, hey, there's a little bit of room for improvement. So, right now, maybe I, as a provider, am only connected to 4, 5, 6, or 20 other eHealth Exchange participants. And at the same time, there are 250 participants. So maybe that's my gap, that maybe that's where I need to head, is to expand my connectivity. And then a lot of people have mentioned the purpose of use. So right now, most of our queries are for treatment and coverage purposes. But there isn't a whole lot going on in terms of emergency healthcare operations, patient request, payment, et cetera. And then, of course, I mentioned the RLS, where we really don't know where to search unless a patient tells us, hey, I went to the ED last week at St. Mary's Hospital, and that's where you should search. So we have some room for improvement here. So the big questions here to me are how can we make data exchange easier? And how can we make it more affordable and timely? And maybe most importantly, how can we improve patient care by making interoperability help patient care be safer and more effective? So I think the first thing, so this is our roadmap, and I'll give you all a moment to just kind of eyeball it, and then I'll get into some highlights. So when we finally do get some more guidance on the TEF, there's the QHIN concept, and of course we don't know enough about it. No one knows enough about it that they can commit to becoming a qualified health information network. But that's definitely a possibility and something that we want to look at very closely. But before we do that, we really need to upgrade our architecture. So, when I mentioned 9-10 years ago, we started out as a ONC incubation project, and we had 4 participants. We had Med Virginia and Kaiser. We had the SSA and the VA. But now, again, we have 250 participants, and the growth of our network is accelerating. It's certainly not leveling off or slowing down. And so the idea that a new participant can come on board and realistically connect to 250 participants is not practical. We have organizations, nationwide organizations in particular, who are really feeling this burden and are saying that they've reached a critical point where we have to make a change. We also know that we need to expand our reach. So we know that, that there's a tremendous interest in care equality, so we're going to make that happen so that, again, you can branch out and realize the benefits not just of one network, the eHealth Exchange, but you can reach out to Epic Care Everywhere, and you can reach out to SureScripts, and you can reach out to eClinicalWorks, and so on and so forth. We need to be able to streamline. So again, there's the promise of FHIR and it being, much easier than HL7 V2, and of course there's the FHIR flavor of clinical documents, and then patient matching. We're not guaranteeing that we're gonna be tackling everything on this roadmap. We're very much committed to the hub, which I'll mention in a moment, and very much committed to care equality and an RLS. But beyond that, we're going to look at things carefully and, be prepared for disruptions and surprises, and continue to gather your feedback and see where we need to course correct. We also know that we need to prepare for natural disasters. I mean, those of you in the Gulf states in particular are very familiar with how the hurricanes keep coming. And if you imagine that you're a volunteer clinician and you're showing up and you're seeing patients displaced from another state, You may not have, and it's severe enough that you're in a school gymnasium or a church, or worse yet, in a tent. You know, you're probably not going to have an EHR there, and you need to be able to look up patient histories so you can provide the best care. Breadth. So this goes back to the purpose of use, the possibility of PDMP, and then Dee Dee's going to come up in a few moments and speak about the possibility of image exchange. And then we're going to have Jen come up and talk about referrals via direct messaging. So if I were to dig into the hub a little bit, again, you know, we started out with the 4 participants. We're up to 250. They're having to create a tremendous number of connections, and it just truly isn't sustainable. So I threw up some somewhat random participants up here now, and Tara, I forget how many eHealth Exchange connections you have now, but something tells me it's in the 5 range. And you were able to set them up fairly quickly, but it doesn't always happen that magically.
When you have a hurricane coming, people tend to
move into overdrive?
Yes.
Yeah. So, so we've got the VHA, and they've got 148 or 184 connections now. And we have the SSA that has over 140 connections. We have another large national provider coming on board in the next month or so, and they're going to want to connect to all 50 states. And so, again, these point-to-point connections just aren't practical. It creates a tremendous burden on the participants to create and maintain these. Meanwhile, there are more value-add activities that they could be performing. So we are planning to move to offer a centralized model. So the idea here is that a participant will be able to create one connection to the hub. And then the hub will branch out to the remaining 249 plus eHealth Exchange participants, and we'll take care of those connections. So again, you create one connection, and the eHealth Exchange takes care of the rest. This also allows us to create a platform for new capabilities. So that allows us to talk about image exchange and talk about FHIR, and talk about a number of other things that we want to do once we have this platform in place. Actually, Jen, would you mind coming up and talking about care equality and where we are with that?
Great, thanks, Jay. So, as many of you have probably already heard on a number of our monthly participation calls, that we have been focused on expanding our reach, and that means us being able to connect to care quality. The coordinating committee has been prioritizing expanding our reach for a number of years, and I think that this is finally the time where we're actually able to do it. And as Jay mentioned, one of the backbones of that is our hub architecture that we're going to be implementing. And it's big green button?
Yes.
Perfect. So there's a number of steps that are involved in order for us to move forward with becoming a care quality implementer. And this process actually started last year with the beginning of the DRSA amendment and making changes to that so that we were able to execute the Care Quality Connected Agreement. And as I'm sure you're aware, it's taken some time. We're still working through that process. We are finalizing that language, and I'm sure you've heard me say that about 5 times, but every time we are really trying to finalize that language. So what the coordinating committee opted to do is to approve moving forward with a care quality pilot, and the goal of that is to really allow us to move forward with beginning to operationalize those processes and understand all of the additional things that we're going to need to do on the network in order for an organization to become a care quality connection. So we have completed the pilot kickoff. The Social Security Administration, the SSA, is going to be the first organization to really move forward as our pilot connection. And then from there, we are focused on, we do have a fee structure in place. So that's going to be about 20% of the current eHealth Exchange participation fee. So it really is nominal cost. And then the Care Quality Connection terms, one of the key pieces that every organization is going to have to do in order to become a Care Quality Connection is to attest to those Care Quality Connection terms in some way. And the way we've done this for the pilot is by incorporating them into a new OP&P, Operating Policy and Procedure, and then those are incorporated by reference into the DRSA. So it will be faster than having to execute another agreement specifically as a Care Quality Connection. And as we move through this pilot process, it'll give us the opportunity to take a look at what additional policy updates are going to be needed, and we are anticipating with the hub architecture and with Care Quality that we will have additional policy updates. Likely nothing that you're not already used to, but it'll just be new for the eHealth Exchange. And then the real goal here is for our participants that are currently part of the eHealth Exchange. Jay mentioned some of our national providers, and we have a few more of those that are currently in our onboarding queue that are looking to expand their connectivity to really allow them to be a Care Quality Connection underneath the eHealth Exchange and to streamline that process of them being able to have access to AthenaNet and eClinicalWorks and probably about 120 plus Epic Health systems that aren't currently part of the eHealth Exchange and intend to remain on Care Quality only. And I think we're going to see just a tremendous uptick. As Jay mentioned earlier, our growth internally has gone, we've doubled in about 18 months. So to be able to fill that gap for the ambulatory connectivity, I think is going to be extremely huge. The only other point I want to mention is that all of our new use cases, our expansion, this is all driven by participants. This is driven by the needs that you've brought to the coordinating committee, and the coordinating committee has had a chance to prioritize. So we're just hoping that you continue to do that. I think.
All right, thank you. Dee Dee, could you come speak about image exchange, please? So there was a question as to whether or not we're going to provide the slides, and the answer is definitely yes. And after Dee Dee and a few others, I'll get more into the hub if anyone's interested.
All right. So some of you may know we have a partnership with the Radiological Society of North America, RSNA. And we are, in fact, there's meetings tomorrow. There'll be folks from RSNA here tomorrow where we're talking about advancing the deployment of image exchange across the U.S. because in other countries in the world, we're way behind. Canada has nationwide, across the entire country, image exchange, across all provinces. There are countries in the world that image exchange was a high priority for them. There are standards. We do have a testing program. We have 9 validated vendors within the Sequoia Project testing program with RSNA that have the capabilities to do that today. So let's see how we can, try to accomplish some of that. So this is probably old school for most of you, but just to remind you, image exchange is really used by about 50% of the specialty clinicians out there, oncologists, not only radiologists, but oncologists, dermatologists, dental, eye care, cardiologist, podiatrist. You think about all these different doctor types that are specialty. Guess what? They don't need labs. They need images more than they need labs. So thinking about that data and what you really need at the point of care to help that patient get better care is important. So some of the things that, really, why does imaging matter? Why is it important? I'm not going to read this, but if you really think about it, even for historical purposes, women, mammograms, they always look at your last few ones, comparing it to your current one to see how it's different. There's things like that that really, it would be great to see those longitudinal images over time. Whenever I go to get a mammogram once a year, they always say, well, where was the last one you had done? If they don't already have that, and they'll pull it. But it's, guess what? It's calling them and having them send it in some way that is not an electronic way usually. Or I get a CD and I have to hand it to my, primary care doctor so that they see it and so forth. The benefits of the historical exams, but then the cost. Imaging is one of the most expensive of the diagnostic tests that are out there. There's also radiation exposure. Using my father, a veteran, he had 5 back surgeries over the last 3 years. there was one point in time where he was referred to an outside health facility, and he had just had an MRI done, but they didn't have it, so they wanted to do another one 2 weeks later. Now, some people don't think about that, but MRIs are pretty radiation intensive. You don't want to have multiples of those over and over again. So these are reasons that if you just look at it from a practical perspective, it's really an important use case to cover. But some of the silos and so forth are barriers. So the barriers are, again, old hat. The biggest one, though, is a data sharing agreement, some sort of governance or policy on how to exchange those images. Because guess what? These hospitals that have these PACS systems in place, or radiology centers that have them in place, they're competitive. They may or may not want to necessarily share that data without some real clear guidelines around it. So we know with the eHealth exchange, we have the plumbing in place to do this. The standards that exist today need some of that policy and governance to help achieve some of that more ubiquitous type of exchange of data. The security and privacy concerns, again, with the exchange that we have in place today, we have a very secure network. We have encryption. We have certificates that are tied to that data sharing agreement and so forth. So we have a lot of that infrastructure in place. So we're really trying to see how can we improve that and add the value-added use case to the hub. So if you think about the hub coming into place, what if we partnered with one or multiples of those validated vendors that we have that we know it's baked into their system, and they can use that same plumbing, the same basic standards that we use for CCD exchange today? Guess what? There is a -I for imaging version of that as well. And the payload, instead of a CCDA document, is a DICOM image. Now, some people say, oh, a JPEG's good enough if you're just a doctor and you're wanting to share it with a patient. But if it's somebody who really, like an oncologist who needs to, really go through the different grayscales and look at the tumors or whatever, they really need those DICOM images. So making sure that those providers can have access to the data and not having the reluctancies that are existing today. The image share use case can really extend the value, and I mentioned earlier some of the standards that exist today. So our eHealth exchange network today are based on our further constraining, so there is an eHealth exchange specification that further constrains IHE, integrating the healthcare enterprise profiles. So the profiles that we use for eHealth exchange, known as cross-community access, XCA, there is an XCA-I version of that. There's also, down to that, what I would call the last mile. So if you're wanting to share within your own gateway, your own regional deployment, an HIE affinity domain as it's known, you also can benefit because there's that last mile piece where within an enterprise or across enterprises, you may have a large 100-hospital system that has multiple PACS systems. I used to work in a university hospital a long time ago that had a PACS system in the cardiology department and a PACS system in the ER and a PACS system in the radiology department. None of those 3 PACS systems talk to each other. So sometimes there's even problems inside an enterprise that this could help with. So just reminding everyone that these standards are something to help different use cases depending on your needs, within your own geographic region, across gateways, or nationally. Along with those base standards, there's well fleshed out ontologies. So RADLEX, which is maintained as a terminology by RSNA, actually is now adopted by LOINC. So it is part of LOINC, and they're maintaining that. So there's even terminologies around some of these things that exist. Not many people know that because they haven't really investigated it, but just to remind folks, the DICOM medical imaging world, they started IHE. Radiology was the first domain because they had a need to be able to share this type of data. The IHE radiology framework has lots of other use cases called scheduled workflow and so forth that even help automate things like billing, everything from the order of the image all the way to the billing of it. So there's lots of things like that that can be achieved. We're looking at trying to see what you need, what would be helpful for you. So we will be, over the next year, as we're looking at the hub deployment, probably going back and asking you guys, what can we do to help you either augment your existing exchange, provide some value-added use case points to that. While we're deploying this, let's see how we can do this for everyone. I'm not saying that we need to, but if there are gaps that we could fill, by all means, let us know, and we're open for those suggestions. So we'll be probably reaching out to some of you guys and making sure to get your input. So be thinking along those lines. The other thing to point out is everybody's talked about fire, the new shiny. All right, fire's great. It's going to solve everything. It's going to solve world hunger. Well, we are looking at fire, because some of the people, putting the negative there too, some people say, oh, these IHE profiles, they're old, they're ancient, they're web services. I'm not going to build that. I'm waiting for fire, because fire is going to be easier to do this with. We've heard that, and I've been working with RSNA to look at what can we do to advance the fire resources that are out there. Because fire's been focused on the US core, data for interoperability, and those data elements or those data classes that are content specific. They've not really talked about imaging or radiology. So RSNA and Chris Carr, who's the director of informatics there, has been working with me and several at HL7 to actually improve the fire concepts and so forth that would also enable the radiology image exchange using and leveraging fire resources. There is a new project. You heard about Da Vinci earlier from Kevin Larson, and you actually somewhat heard a little bit about that part from the payer perspective. Well, HL7 and IHE combined to create something in April of this year called the Gemini Project. Gemini Project is a collaborative. There's a memorandum of understanding between IHE and HL7, and they're actually taking and finding ways to work together to not only create what I would call the actual standards, but the testing tools. So some of the strengths that IHE brings to bear are those testing tools. HL7 is also looking at how do we improve those standards. They're having connect-a-thons, IHE has connect-a-thons, so now they're combining that work. I'm on the steering committee. I'm one of the 3 IHE representatives on that steering committee, and there's 3 HL7 representatives. And what we're going to do is we're going to take the DICOM web work, which is the fire for DICOM, and what we would call the some of the cancer care project. So we're going to focus in on cancer, because that is something that we feel that would be a use case that would be useful, because imaging is very needed there. It could be breast cancer, it could be liver cancer. We're still determining those pieces. But just 2 weeks ago, the Gemini Project approved the actual use case for image exchange. So we are planning for the January Connect-a-thons, both at HL7 and IHE, to take that to the next step and actually take and utilize the tools that we have. NIST, the National Institute of Standards and Technology, have actually been developing some of these fire standards along with Mallinckrodt Institute. So some of these things they're looking at, they're actually receiving funding to improve those tools. So we're looking at how could we use those tools to better improve the RSNA programs as we move forward. We just relaunched a new version of the RSNA image share testing program this year that added security and some metadata and things like that you really need to really use meaningfully the exchange of images. So now we're trying to see what next steps we can take, and fire is what we're kind of focusing on right now. This is an example of an architecture, just to kind of give you a picture of what this image exchange might look like in your own geographic installation or implementation. So if you look over here to the far left part, think of that as the hospital, the imaging center itself. So that's one silo of data. That's something that may be recognized by you. You've got a PACS system. You've got the RIS system, and you've got the hospital. There may be multiples of those in a geographic region, or as I mentioned earlier, you may have multiple PACS systems inside one hospital in and of itself. That data in that silo needs to be shared out. A lot of these vendors have been adopting what's called VNA, the virtual network access to the actual images. They're actually the ones that we're testing. So if you're looking at it from a cloud perspective, what if they push some of these things to the cloud with the patient's permission, or the patient decides they push it to the cloud? These are possibilities that actually have been baked out. So RSNA actually received a grant from NIH to figure out how to engage patients in this image exchange. So this architectural diagram is something called the RSNA Image Share Network. They were funded for a few years. This is an example to show you what's real. They had 35,000 patients sign up But the network is no longer being subsidized, but these patients are still using and leveraging it. A lot of these patients were research patients, oncology patients, and so forth. But this is one example of something we could take as a value-added component and plan for onboarding multiples of these networks. Some of these large radiology centers that may have large numbers of images for a geographic region may be something we could onboard to a hub and make available to multiples without you having to have those point-to-point interfaces to each one of those. These are the vendors that have actually been validated. We have 9 to date. We have some new ones coming in for testing leading up to the RSNA conference just next month. And we're hoping that we can continue evolving that. We encourage you to talk with your vendors and ask them how they support the standards and so forth, so that we can make sure we can start growing the vendors who have baked in this capability into their system, so we have more than one option. We don't want to have to say, here's only one partner to do this with. Probably out the gate, for a pilot, we would want to do it with one partner, but we would want to make this something that, is useful and leverageable by multiple vendors as we go. So that's the image exchange use case part of it. And with that, I think I'll turn it back over to Jay.
Thank you, Dee Dee. All right, so the next thing that's on our roadmap is PDMP access. So we are in active conversations with 3 PDMP vendors and of course the owners of that data, the various states across the U.S. That are expressing interest in this. And this is not by any means a slam dunk. There's certainly the appreciation that PDMP data is most valuable within the physician's e-prescribe workflow. So this isn't intended to be end-all, be-all. But the question is there significant value if we were able to query some of these state databases managed by Appriss Health and managed by RxGov and the others? And we were able to pull this and pull not only the controlled substances that are listed there, but also pull the toxicology reports, also pull the risk scores, as well as other psychosocial observations. And I believe that that would be of tremendous value to the cross-functional care team. So again, maybe not for the physicians who are performing the e-prescribe, but for the rest of the team to be able to see, hey, there was a positive toxicology result, or hey, the risk score for opiate abuse is high or low. That might be of tremendous value. Again, we've spoken about purpose of use, but again, we have the SSA is currently pulling about one, and Claretto for life insurance purposes are currently pulling about 1.5 million documents over the eHealth exchange last year, and that's going to increase significantly this next fiscal year. And then there are about 200 million documents going across the eHealth exchange annually, but again, primarily for treatment purposes. Not a whole lot of operations, payment, emergency, or patient request. And that's something we can definitely work on to improve. And that's going to involve work with some EHR vendors and others to see what barriers are there that we want to address. So I'm going to mention briefly Pulse. So I mentioned this before, and Marianne and folks at ONC are going to get into this in much more detail tomorrow at the Sequoia project meeting. And again, if you were not aware of this or hadn't registered and you're interested, please go out to the registration desk, and they can get you set up to come in tomorrow morning to hear about everything going on at the Sequoia project. But Pulse is an application, and the eHealth Exchange is the network for this application. And Pulse is used, again, in disaster recovery situations where patients have been displaced. As Tara mentioned, maybe they had to leave Florida to go to Georgia due to a hurricane. And when it gets really severe, they might be going to a tent or, as I mentioned, a school gymnasium where there is no EHR. And to avoid flying blindly, the physicians and other clinicians need to log into Pulse, access the eHealth exchange, and pull back patient histories. So this is something that we need to integrate to the hub so that there aren't those 250 point-to-point connections that I mentioned. Eric, could you come up and talk to us about FHIR and patient matching, please?
Thank you. So I just have to say, too, how cool is Pulse? I mean, physicians, when they deploy this, can go anywhere in the United States. If they have a Pulse deployed system, if they're in a tent out there servicing people displaced by a hurricane, they can still get patients' problems, medications, allergies. So, if a patient walks up and says, I've got a heart problem, I take white pills, I need my medicine now, they can actually be serviced. So I think it's pretty exciting. I don't want to speak for the CMS, of course, but my understanding also, in case you're not aware, is 90%, 10% IAPD match funding is available from the CMS, and that's a limited time. I think those funds expire in 2021, so that's. I'd encourage you, if that's a possibility, to work with your ACOs or your state to actually apply for the Pulse funding. If you actually want a live demo, come grab me sometime. I actually have it here at the conference, and so be glad to spend 5 minutes with you and show you Pulse as well too. So I just want to say before I get started too, with my very brief remarks, I'm very overwhelmed to see so many people here too. I mean, and I know Sequoia staff has really been driving and facilitating, moderating, but really the credit for all the success, it's not because of us, it's really because of you. And I just want to thank you all for your support, our federal partner and friends for all their support, because we really wouldn't be doing this without you. And we're doing this, we continue to be doing this for you as well. So Jay asked me to talk about 4 areas on the roadmap that we're considering, and we really want to get your feedback on this to see if we're course correcting or if we actually are on the right track. So the first one is the directory. So the eHealth Exchange today, as you're probably aware, it has a directory typically called the UDDI. But how many people actually are aware that today in production we also support FHIR for the same directory? Yeah, okay, only a couple of you. So the current production eHealth Exchange directory supports FHIR live in production right now. And so one thing you could ask your vendors, if you're a participant, is to have them start working on switching over from the UDI legacy interface to the FHIR interface. That would give them a lot of capabilities. It'll align the eHealth Exchange directory with the Care Quality directory. It adopts a contemporary standard FHIR, which is based on the Argonauts work, which we help facilitate as well too, and supports much broader data exchange. Dr. Donahue talked earlier about essentially the plug-and-play onboarding. That's something we also want to support. And one of the benefits of a FHIR-based directory is actually it takes us farther down that path. For example, it supports the use cases in the FHIR directory right now today for the eHealth Exchange membership. It supports purposes of use. So if you can actually tell in advance if a purpose of use your organization wants is actually supported by a partner that you're also seeking exchange with, or if you need to pick up the phone and talk with them or not. It also conveys what kind of content you may be generating and what you can consume, what your partners can generate, what they can consume. And then also, most importantly, in many ways, the directory is intended, and this is a roadmap issue where, again, we want your feedback, to actually have patient demographics stored in that directory as well, too, for synthetic test patients. And the problem this is intended to solve, back to the plug-and-play onboarding, right now, I'm not sure about you all, but whenever I see an HIE or an eHealth Exchange participant being deployed, almost inevitably, you have to pick up the phone and talk to your key partners and say, give me some demographics of a test patient that's opted in so I can hit you and make sure things are actually working correctly back and forth. Well, this actually solves that problem. And so now, test patients could be added to the eHealth Exchange FHIR directory. Again, let us know if that's something that's important to you. We think it's pretty important, but we really need your feedback and guidance, especially to Jay, about whether or not that's also something that would help you. Another area is patient matching. So just out of curiosity, do a quick little survey. By show of hands, how many people think patient matching between your organization and your other eHealth Exchange partners is actually a small problem, medium problem, or large? So first of all, how many think it's a small problem? It's not too severe of an issue. Okay, how many people think patient matching is a medium severity issue? Okay, and how many people think it's a high severity issue? So, Okay, great. So the reason I asked that, we also thought a few years ago that was what you're telling us too. This is still a problem that needs to be solved, and so we've been working diligently on that. So we actually published a paper, and actually a lot of you helped. We had, I think, over 300 organizations and people help provide comments on that paper overall over time. It's now published in final format for patient matching across organizational boundaries. But that was just actually one step in the process we have in mind. The next step we have in mind is to work with you to create a test case library of, pass, fail, are you conforming as far as matching patients across organizational boundaries, but even more importantly, what's the quality of the matching? Maybe you match, but perhaps you don't match when you should be because your algorithms are actually not up to, best practices or even current practices or even minimal practices. And so one thing we have in mind to do, and again, we'd like to get your feedback on this, is would a test patient matching library of test cases we all together create be of use to you? Another thing we'd like to do on top of that, if it makes sense with you all, is to actually turn that into and add and augment that with an executable test case system and also with test patients. What I'm really kind of envisioning is a library potentially stored in the UDI, or the FHIR-based equivalent of that, of test patients with various demographic characteristics, such as some that are very similar that actually should not match, or some that actually are very similar but should match, that type of thing, so we can actually assess pass or fail, as well as quality of each of those organizations in a programmatic, factual-based manner, as opposed to really kind of an ambiguous manner like we may be facing today. And the final thing Jay asked me to talk about beyond patient matching is piloting a notification feature. The standard's actually already out there for notifications. We actually have quite a few standards for notifications. We have FHIR. FHIR can not only query, it actually can push. You can actually use WebSockets, which is a way two FHIR implementations can talk to each other in real time back and forth. You can push with FHIR. You can query using FHIR. So that's one standard. We could use XDR, which is an IHE profile. It stands for Cross Document Retrieve. There's actually a push capability as well, too. There's DSUB, another IHE profile. There's even more profiles on top of that as well. So ADT, HL7V2 world, like Sheik and others are using as well, too. So one thing I'd like to get your feedback on is, do you need notifications, where something is sent from either the hub or from your colleagues in other areas of the country to you? If so, what are the use cases around that? So again, those are some key things on our roadmap that we have in mind that we think you're telling us are important, but we really need to do next is really hear from you. And so please talk with us, talk with any Sequoia member, talk with Jay especially, and let us know what we can do to serve you better. So thank you.
All right, thank you, Eric. Yeah, so again, our intent is to make the roadmap very flexible and be able to respond to new market disruptions. But we do know that we're going to be implementing the hub as well as carry quality. And when I talk about carry quality onboarding, I'm also talking about the SureScripts option. So SureScripts offers a service called RLE, Record Locator and Exchange, and that will be available to participants who choose to onboard to carry quality via the eHealth Exchange. It'll be an additional option, and SureScripts does charge fees for that service, typically. I should mention that if this is confusing to any of you, please remember that many participants already have access to carry quality, and they're enjoying its benefits right now. So if you're a provider running Epic, as an example, you probably have access to carry quality through Epic Care Everywhere. If you run Cerner, and of course Commonwealth still in its early days as a carry quality implementer, but you probably can elect to onboard to carry quality via Commonwealth. So this may be something that you choose not to do through the eHealth Exchange. So you have lots of options, and I can explain that to you separately if it's still a little mystified. Commonwealth does plan to offer an RLS to its carry quality implementers down the road, but that's not available right now. But the beauty of the RLS or the RLE overall is it tells you where a patient has been. So instead of having to query blindly where you're not sure where a patient may have been, it can say, hey, patient J has been to locations A, B, and C, and maybe that's where you want to go ahead and query. So I'm very excited about offering this to the eHealth Exchange participants. Jen, could you talk about the referral use case again, please?
All right, so is anyone aware already that Direct has been approved as a transport mechanism on the eHealth Exchange? Eric Heflin wins that one. Oh, and Dee Dee. Okay, 2 people. So the coordinating committee actually approved Direct probably about 3 years ago, and just like anything else that comes to the coordinating committee, we had an organization that was interested in potentially utilizing that. And what's happened with some things and some other use cases that have been approved is that ultimately we have a participant that chooses not to move forward with that. In the case of Direct, a company called DSS has been working with the VA on various other types of projects and recognized that there was a gap between what the VA could do for direct messaging with private sector participants. One of the limitations is that the VA had to have an agreement with those organizations in order to be able to send direct messages. There were some other policy limitations. So the VA wanted to potentially be able to expand that via the eHealth Exchange, and the coordinating committee moved forward with approving a pilot for this. So essentially, DSS is an organization that has gone through the Health Exchange onboarding process and has been approved as a pilot participant to serve as a vendor intermediary on behalf of the VA. So the real goal of what we're expecting to be able to happen is that a VA provider within their current software right now can initiate a referral and actually look up their community care providers. So this is for any provider outside of the VA that one of their veterans might be being referred to for treatment. And then initiate that referral package to be sent to DSS. So DSS being an eHealth Exchange participant and the VA being an eHealth Exchange participant under the umbrella of the DRSA are able to do that exchange without having to enter into any additional agreements. And then the goal would be for DSS to be able to forward that referral package to that individual provider via their direct email address. And then there would be the return path. So that provider would be able to reply to that and send the results back for the VA to be able to put within their system. So this is currently a pilot. It's very close to all of the pieces being in place. And we are looking for an eHealth Exchange participant that would be interested in participating in this pilot. Right now, I think we had been targeting the California region. But I think we're looking at pretty much any eHealth Exchange participant that would be interested in supporting that. And essentially, you would be looking to be able to receive direct messages from VA providers for any veterans that are seeking care in your facility. So we're excited about this. We'll be sending out additional information about it. We do have a representative from DSS here as well, who can answer any additional questions. One other key point that you can see on the bottom there is that DSS is currently utilizing SureScripts as their HISP, and that's how those messages are would be going out to you. Any questions on that right now? All right. Thank you.
All right, thank you, Jen. All right, so the roadmap. So again, no hard and fast rules. We do know that the hub, carry quality, and the RLS are our top priorities. I would personally, depending upon your feedback over the next X number of months, love to move into Fire next. as well as the Pulse integration. It's kind of an open door. We're going to start to have some weekly teleconferences or WebEx where you can start to ask questions about the hub or get get a one-on-one with detailed questions about it, because we do want to make sure that everyone understands how it's going to work. So if we want to perform kind of a drill down with additional context regarding the hub, this might be overwhelming for many of you, so feel free to tune out for 30 seconds if it is too much. But basically, the hub becomes a middleman here. So the idea here is that our participants are going to have the ability to send all of their queries, all or most of their queries, to the hub, and let the hub forward that over to the responder. Let the responder, let's say it's another health system, perform the patient matching, and return that back down to number 3, and then have the initiator query for documents, have the hub forward that message on to the responder. And of course, the responder will forward a message to the hub, and the hub will forward that to the initiator with a list of documents. And then the initiator will say, hey, I want 1 or more documents, forward that to the hub. The hub will forward that to the responder. And then the responder will return the document to the hub, and the hub will forward that to the initiator. Again, the intent here is to simplify the world where we have 230 plus connections just to other eHealth Exchange participants, and then another 140 or so connections to Care Equality, which is really an overwhelming architecture for most organizations. So, we're going to start with the hub and Care Equality and RLS, and then there are a variety of different features which we can add to the hub as demand surfaces or doesn't. So, one thing that our vendor is prepared to do is to perform quality scans. So if our participants are interested, we could do something along the lines of randomly check the documents that you're receiving from other participants, run them through our validation tool, and look for hopefully intermittent or systemic quality or consistency issues. And so that way we can contact that participant and say, hey, did you know you're using the wrong LOINC code for XYZ, or whatever the example might be. The other thing that our vendor is prepared to do is to make us FHIR enabled. So that could be at a minimum where we could translate clinical documents, where we receive an IHE clinical document and translate that into FHIR, or the opposite. We could also use that for more discrete transactions, where maybe an eHealth Exchange participant says, hey, I only want to pull back medications, or hey, I only want to pull back lab results. And that could be done by FHIR if that's of significant interest to our participants. Our vendor is also prepared, if we have enough interest, after we get the initial system set up, to implement the push notifications that Eric mentioned. So instead of potentially waiting, or instead of potentially having to query and retrieve, we could have documents automatically arrive if we maintain your patient census, if you're comfortable with that operation. And then, if needed, we can certainly look at the patient matching challenge and say, is the entire ecosystem better suited by having that happen centrally? And of course, that would require a tremendous amount of analysis and buy-in from the participants, but that's always on the table, especially if that's something that is required for QHINs. So what's it going to cost and what's it going to be ready? When's it going to be ready? The reality is we are in the very final stages of procuring the hub. And our hope, and our vendor assures us, and I've been a vendor a few times, so I take it with a grain of salt, but our vendor assures us that they can have a good number of our participants live, a huge number, within 4 months. So, again, take that with a grain of salt. Again, we're still finalizing our financial model, but our goal is absolutely to make this a no-cost or low-cost endeavor for the lion's share of our participants. So stay tuned for that. We do at a minimum have our monthly all-participant calls, typically on the third Thursday of the month, and that's where you can expect to get an update on that. If you do, however, have questions in the interim, feel free to reach out. If you don't have my email address, believe it or not, just by emailing the email address on our website, administrator@ehealthexchange.com or administrator@ehealthexchange.org, I will absolutely get it if you send it in that direction. So, again, Margaret kind of went over this earlier, but why is there a problem? If it isn't broken, why fix it? And again, the reality is that many of our participants are at that critical point where they're saying, hey, this point-to-point architecture was wonderful for the first X number of years. It served us very well, but times have changed, the network has grown, and we need to move on to a more practical architecture. Why the hub? Again, to me, it's painfully obvious, but I've been looking at this for quite a while. But it's your opportunity to really simplify and redirect your time and money to other more value-add propositions. And then why now? And again, we're at that critical breaking point where it's too onerous to honor the duty to respond in the DRSA and set up 250 connections if you exchange for treatment. And then if you choose to onboard to Carry Quality through the eHealth exchange, it's really an overwhelming task to ask you or expect you to set up 140 plus connections just with Carry Quality to honor their required non-discrimination policy.